Very good afternoon to everyone. So I will be speaking on cataract and trabeculectomy, when and how do we do it. So cataract and glaucoma are both problems of an aging population, and the primary aim of glaucoma surgery is to lower the IOP to reduce the progression, and that of cataract surgery is visual rehabilitation. The choice of combined surgery depends upon the severity of glaucoma and the vision impairment due to cataract.
Can you speak a bit louder? It's not audible.
Right. Combined cataract and filtration glaucoma surgeries has certain advantages, which is primarily the convenience of the surgery and to avoid a post-op IOP spike after cataract surgery. The primary disadvantage being that it is usually less effective for IOP control than glaucoma surgery alone, and there is also increased inflammation, and there may be challenges in doing the cataract surgery as well due to problems in the cataract, as the cataract may be more difficult surgery. So what is the indication of combined surgery? So you have a patient with a visually significant cataract and adequately controlled IOP but significant AGM side effects, adequate IOP control on 2 to 3 medications but advanced glaucomatous optic atrophy, and borderline IOP control on 3 medications at any stage of glaucoma. When not to do, this is also very important. So very high pressure glaucoma where the IOP control takes priority, a trabeculectomy may be better. And an incipient cataract with mild visual impairment and uncontrolled glaucoma, again a sequential 2-stage approach may be better. You do the trab first, and then go for a cataract surgery 3 to 6 months later. Again, if the IOP is well controlled on 2 medications, the patient has an early glaucoma with visually significant cataract, just a cataract surgery may suffice unless drug compliance is a problem. There may be some difficult situations or difficult decisions. For example, in patients with acute or chronic PACG, you have a very high IOP, unrelenting pupillary block, visually significant cataract, and advanced glaucoma. Again, here one must emphasize the importance of adequate medical management and a combined surgery with a very guarded visual prognosis done by an expert. In lens-induced glaucomas with chronic presentations, so for example, late presenting phacomorphic glaucoma, a combined surgery that is undertaken may be ECC or SICS trab, and in phacolytic glaucoma, again, intense steroids initially for inflammation controlled, and the risk of corneal decompensation should also be mitigated and expected and explained to the patient. And patients with sublux lens with pupillary block, again, lens removal with iris fixing IOL or a scleral fixated IOL with or without a trab, the decision again has to be taken by an expert surgeon. Preoperative evaluation, one has to see the glaucoma medications, the best corrected visual acuity, the intraocular pressure, slit lamp evaluation, and the cornea too. You have the gonioscopy, optic nerve exam, the visual field and optic nerve testing, and after adequate counseling, the decision regarding a single site procedure, a single procedure, cataract or glaucoma surgery alone, or a combined surgery may be done. Special consideration, preoperatively one may stop or switch the PG analog to another drug a week prior, may start low potency steroids for a week, start oral acetazolamide if there are no contraindications 48 hours prior, and pre-op mannitol and glycerol, again with all adequate precautions just prior to the surgery. Again, in these cases, periverbal anesthesia may be preferred as the duration of surgery is longer. Of course, some experts do it very quickly as well. And special considerations in cases where there is poor mydriasis, again high density OVT where there is endothelial problems, and trypan blue or mitomycin C as per requirement. So types of surgery, phaco trab is usually done 2-site, SICS trab is done as a single site procedure, ECC trab is usually a single site procedure. So the advantage of a single site procedure is that it saves time, and the primary disadvantage is that there is excessive conjunctival manipulation that may lead to a trab failure. 2-site surgery technique for cataract surgery, definitely there is improved exposure through a temporal approach. For a trabeculectomy, it enhances bleb survival and there is rapid visual recovery. The primary disadvantage is that it may take longer. IOP control with single site or 2-site, both approaches are effective, but a 2-site may have a better IOP control. So how do you do a 2-site technique? So you may give a subconjunctival injection mitomycin C, which is my preferred choice. You leave a conjunctival flap and then dissect thoroughly posteriorly, irrigate the area well to remove any leaking mitomycin C, dissect the scleral flap well into the limbus, very careful dissection, and then after this we proceed on. Once this is done, we move on to the cataract surgery. We move temporally, shift the microscope, and cataract surgery is routine. You just leave the flap there and then go ahead and do the cataract surgery, implant the lens, and then move back again posteriorly. With the visco in situ, we create the ostium, and the visco inside prevents AC collapse. I also like to do a releasable suture to provide against additional insurance against a bleb failure. Releasable sutures are very convenient here. Yeah. And then once the surgery is complete, we just used buried conjunctival flap knots. Buried knots again prevent irritation to the patient. Yeah. And complete the surgery with intracameral moxifloxacin. Again, avoid subconjunctival gentamicin to prevent bleb failure. Single site phacotrab is, as you can see in this photograph, is done. The phacoemulsification is done through the same site as the trabeculectomy flap. And most surgeons have now shifted from single site to two site because the failure rate with single site tends to be higher, and hence I'm not showing surgical video for that. SICS trap is again usually single site, a superior peritomy with mitomycin C, a sterile tunnel is done for routine SICS, and entry is usually slightly posterior than usual. The SICS, a routine SICS is done, IOL is implanted, following which you can use a Kelly sponge to just do the sclerectomy, and then the iridectomy, and then the conjunctival closure is done. And then, yes, the flap can be sutured as a single suture. One can use a releasable flap also for this procedure. It is a surgeon's choice. And then you just close the conjunctiva. Yeah. So postoperative management is similar as that of glaucoma surgery, just that the patient has to be seen on the first post-op day and then weekly again. If there is significant inflammation, more visits may be necessary. Post-op, usually you give antibiotic steroid, and steroid tapering is usually slower. Cycloplegics given in PSCG. And complications are similar to that with cataract surgery alone or with TRAB alone, but the risk of persistent hypotony and endophthalmitis is increased with antifibrotic agents. So take-home messages: avoid combined surgery in high IOP situation due to high failure rates. Pre-op steroids may be useful. Two-site surgery with antimetabolites ensure higher success rate. Avoid subconjunctival gentamicin. Prefer intracameral moxi. Avoid aiming for hypotony. Visual rehabilitation is better. Use releasable sutures, which is an insurance against bleb failure, and SICS and TRAB may be taken, or ECC TRAB may be done in difficult situations. Thank you for your patience and time.
Thank you, ma'am. Nice talk. How many releasable sutures you use?
So it again varies. One can use even 3 releasable sutures, or you can just put a tip releasable and 2 side sutures. Depends. If you once you put the releasable, you look at the filtration through your ostium after removing the viscoelastic. And if it is over-filtering, you can go ahead and put 2 more releasable sutures. You remove the viscoelastic.
What is your routine?
My routine is 1 releasable and 2 side sutures. I usually do that. And sometimes I might use 2 releasable sutures.
Will you do combined surgery in a uveitic with cataract?
Yes. So I would not prefer to do a combined surgery in a uveitic patient. I would, if the IOP is high, I would go for the TRAB first and then leave the patient alone, because the inflammation risk is too high. So if I have given a posterior subtenon or a Ozurdex and the inflammation is taken care of by my retina colleague, then I might think about doing a combined surgery. But in a uveitis patient, I would distinctly avoid it. I would go for a 2-stage procedure instead of a single surgery.
Combined surgery with nasal trap?
Combined surgery with?
Nasal trap. Nasal in the nasal quadrant.
Yes, because you want to preserve the other quadrants in case you, usually in glaucoma patients, it's a good idea not to use up the entire conjunctiva, because there is a very high chance the patient might require repeat surgeries. So if you put it to the nasal side and then you have more conjunctiva left, if you want to do a repeat trap, and then if you want to do a GDD later on. So it may be a good idea to just do it in a small area. And I do the nasal side, but I do the temporal side also. But I usually leave adequate conjunctiva for any procedures that the patient might require later. So I usually leave as much of conjunctiva untouched as far as possible, sir.
Sorry, failure rate.
Failure rate, again, sir, I don't have the data for it because I have not looked at studies, but generally failure rate of combined surgeries is slightly higher than that of TRAB alone. That is, but this again, as I said, I do not have the data for it. But yes, that is primarily related to the inflammation. But in experienced surgeons, I've seen many experienced surgeons who have a good success rate with combined surgery alone. Now, if again, success can be either a complete success or a qualified success. If you do a TRAB alone, you're most likely to get complete success. If you do a combined surgery, you may have to add on a drug maybe, but so you would end up with a qualified success at least with the patient most of the time. So, yeah, so in where it is indicated, it may be done.